Now we turn our attention to the pathology portion of this lecture. Accordingly, we'll discuss a wide variety of psychiatric illnesses. We'll attempt to simplify this incredibly boards-relevant topic, but with that in mind, you'll also need to return to this topic and study it well, as many of the conditions discussed herein will be tested on the boards. Many students feel that this material should be somewhat self-explanatory, but at the level of detail Step 1 frequently tests this material, trying to answer questions without at least a little memorization will probably drive you crazy, pun intended. There are many effects to be familiar with when infants are deprived. Most are long-term, in the greater than 6-month time frame, but severe short-term deprivation can even lead to infant death. The main effects are decreased muscle tone, poor language skills, poor socialization skills, lack of trust, anaclitic depression, weight loss, and physical illness. These can be remembered with the 4 W's mnemonic, like wah, 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 wah. Weak, wordless, wary, and social wanting. Child abuse is not only a boards-relevant topic, but also very important for your clinical experience. There are 2 main types of child abuse that you'll be expected to understand: physical abuse and sexual abuse. Physical abuse may manifest as a child with multiple healed fractures on X-ray, cigarette burns on the skin, subdural hematomas, or retinal hemorrhages or detachment. Sexual abuse often manifests as genital or anal trauma and may even present as a child with STDs or UTIs. The most common culprit for physical and sexual abuse historically has differed. Physical abuse is usually inflicted by the primary caregiver. This is often a female. Sexual abuse, on the other hand, is usually inflicted by a male, and it's usually someone known to the victim. In terms of relevant epidemiology, physical abuse leads to about 3,000 deaths per year in the U.S. The thing you'll want to remember about sexual abuse is that it's most common in the 9 to 12-year-old age range. Child neglect refers to the failure to provide a child with adequate food, shelter, supervision, education, and/or affection, and is the most common form of mistreatment. Children will usually present with poor hygiene, malnutrition, withdrawal, impaired social and emotional development, and failure to thrive. Such clinical scenarios must be reported to Child Protective Services, even if this violates doctor-patient confidentiality. On a similar note, reporting suspected elder abuse is also mandatory in most states. Now let's discuss some childhood and early onset disorders. ADHD is characterized by a limited attention span and poor impulse control, as well as hyperactivity, motor impairment, and emotional lability. It has a normal age of onset of around 7 years. Children with ADHD often have normal intelligence, but commonly have difficulty in school. Up to 50% will continue to be affected as adults. There are 3 main treatments: methylphenidate, better known by the brand name drug Ritalin, as well as atomoxetine, a non-stimulant SNRI, and amphetamines like the brand name drug Adderall. Of course, many of you know that there's a lot of controversy over the use of these drugs in the U.S., with many experts believing that we're over-medicating our children for normal childhood behavior. Next is conduct disorder. This refers to repetitive and pervasive behavior that violates social norms, often manifested by aggressive and destructive illegal activities. By definition, this disorder must begin before the age of 18. If it begins after, it's referred to as antisocial personality disorder. We'll discuss this in great detail later. Oppositional defiant disorder is characterized by a pattern of deviant behavior towards authority figures, though the child does not really appear to be outside of social norms. Imagine a child who often talks back to teachers. The next disorder is well known and often misrepresented: Tourette's syndrome. It's characterized by a sudden, rapid, recurrent, non-rhythmic, stereotype motor movement or vocalization. These are called tics. In order to qualify, they must persist for more than 1 year. By most estimates, it affects between 0.1 and 1% of the population. Popular media often demonstrates these patients suffering from coprolalia, or obscene speech. This only occurs, however, in a minority of patients, about 20%. There's also a strong association with OCD. It's often treated with antipsychotics such as haloperidol. Separation anxiety disorder is where the child has pathological anxiety about being away from home or loved ones. This can lead to nightmares and physical complaints that are real or imagined, often as a way to avoid going to school or being otherwise separated from the parent. It usually shows up before the teen years, and it's not to be confused with separation anxiety, which is part of the normal milestone development in infants and toddlers. Pervasive development disorders are characterized by difficulties with language and the failure to acquire, or the early loss of, social skills. The first 2 diseases are often viewed as part of a similar spectrum: autistic and Asperger's disorder. Autism refers to severe language impairment and poor social interactions. Usually autistic children, more often males, focus on objects rather than people. These children often show repetitive behavior like flapping their arms or hands, and below normal intelligence. In only rare situations, these children will have unusual abilities. These people are referred to as savants. The most effective treatments for autism have been behavioral, supportive therapy to improve their communication and social skills. Asperger's can be viewed as a milder form of autism with similar repetitive behaviors, difficulty with social skills, and obsessions with certain interests like memorizing the prices of Lego bricks on eBay. Unlike autism, Asperger's kids normally have normal intelligence, usually without any verbal, language, or cognitive deficits. Popular culture often makes reference to this disease in the context of individuals who excel at academics because of an obsessive love of studying but who function poorly in social situations. Rett's disorder is a dominant X-linked disorder. It's seen almost exclusively in girls because males with this disorder die in utero. Most cases are caused by mutation in the MECP2 gene on the X chromosome. MECP2 stands for methyl CpG binding protein 2. If you realize that MECP proteins play a role in gene suppression in nerve cells, then it becomes easier to understand how this disorder develops. Symptoms of regression usually start at ages 1 to 4 and are characterized by loss of development milestones, mental retardation, loss of verbal abilities, ataxia, and a classic hand-wringing behavior. In contrast to autism and Asperger's, this disease involves a loss of development as opposed to an initial failure to develop. Childhood disintegrative disorder, also known as Heller's syndrome, can look a little like autism, except children start off normally for at least the first 2 years of their lives. At that point, they can start to lose significant expressive or receptive language skills, social skills, or even organic functions like bowel and bladder function or the ability to play. It often begins between 3 or 4 years of age and happens more commonly in boys as opposed to Rett's. You can keep the gender preference straight by remembering that CDD and boy are shorter words than Rett's and girl. While it may not seem like it, this is a very boards-relevant fact. As you may know, these are some of the more common neuropsychiatric diseases that we'll see in clinical practice. It's important to know the patterns of neurotransmitter change with disease because many of the medications aimed at treating these diseases will attempt to push the neurotransmitter changes back toward normal. We'll discuss these diseases in greater detail during the pathology sections of psychiatry and neurology. We'll also come back to these neurotransmitter patterns when we discuss the pharmacology. Orientation refers to a patient's ability to know who they are, what time of day it is, and what their circumstances are. The most common causes of loss of orientation are alcohol, drugs, fluid and electrolyte imbalances, head trauma, hypoglycemia, and nutritional deficiencies. Usually when people lose their sense of orientation, they first lose their sense of time, followed by their sense of where they are, and finally, loss of their identity. If they are oriented with respect to all three, we refer to them as A and O times 3. There are 2 directions that amnesia can occur. First is retrograde amnesia, in which people lose the ability to remember things that occurred before a CNS insult. In contrast, anterograde amnesia refers to a situation in which people cannot form new memories of events that occur after a CNS insult. Korsakoff amnesia refers to a classic anterograde but also potentially retrograde amnesia caused by thiamine or vitamin B1 deficiency. This leads to bilateral destruction of the mammillary bodies. These are located on the ventral surface of the diencephalon. Classically, this is found in alcoholics and is associated with confabulations. Dissociative amnesia refers to an ability to recall important personal information, usually following trauma or stress. This is similar to dissociation, one of the immature defense mechanisms mentioned earlier, but differs in that it includes memory loss. Cognitive disorder is an umbrella term that encompasses both delirium and dementia. We'll talk about these in a moment, but this can refer to any general change in cognition, including memory, attention, language, and judgment, all from a previous level of functioning. It's often seen in the setting of CNS disorders, medication use, general medical conditions, or substance abuse. Delirium and dementia are very boards and clinically relevant topics. Delirium refers to a waxing and waning level of consciousness with acute onset, thus the saying, delirium affects the sensorium. It is characterized by acute changes in mental status, disorganized thinking, hallucinations, usually of the visual type, illusions, misperceptions, disturbances in the sleep and wake cycle, and cognitive dysfunction. This is an incredibly common illness in the hospital setting, as patients with CNS disease, infection, trauma, substance abuse, etc. can often experience delirium. Classically, it may also occur as a side effect of drugs with anticholinergic effects, so it's always important to look for the underlying cause before you pull out the antipsychotics and benzos. Another important point is that delirium, unlike dementia, produces an abnormal EEG, although you wouldn't normally check that on a medical or surgical floor. In contrast to delirium, dementia is a more subtle and gradual decrease in cognition, with no change in the level of consciousness or EEG readings. The hallmark here is memory loss, but you can also see aphasia, apraxia, where a person can't follow a command even though they understand it, as well as agnosia, or loss of judgment. Another important distinction is that dementia is often irreversible, unlike delirium. The common causes of dementia include Alzheimer's, vascular disease, Pick's disease, HIV encephalitis, and several others. You'll also want to look for depression, especially in the elderly, as it can lead to pseudodementia, which is possibly reversible. We'll discuss these disorders in greater detail during the neurology chapter. Psychotic disorder is a fairly broad term that refers to distorted perception of reality involving delusions, perceptual disturbances, and/or disorganized thinking. It's often seen in psychotic disorders such as schizophrenia and delusional disorder, but may also be a symptom of mania, depression, general medical conditions, or substance abuse. These terms all represent forms of psychosis and can be confused, so let's spend a little time talking about them. Hallucinations refer to sensory perceptions that occur in the absence of real stimuli, while an illusion refers to a misinterpretation of a real stimulus. For example, if you saw a light which was not present, it would be a hallucination. However, if you saw a light and thought it was the sun, it would be an illusion. Delusions are strongly held beliefs that are not shared by most people, and that are maintained despite proof to the contrary. For example, you could have an individual who believes the CIA is spying on him, which, could be true, but most likely isn't, and is something the majority of people wouldn't believe. Loose associations are a manifestation of disorders in the form of thought. We'll discuss them in greater detail in this section on schizophrenia. There are hallucinations associated with every sense. It's important to understand which types of hallucinations are associated with different pathologic processes. For example, visual hallucinations, such as the aforementioned light that isn't there, are often seen in patients experiencing delirium. Patients with schizophrenia will classically have auditory hallucinations. These patients may also have visual hallucinations, however, albeit less commonly than in delirium. These auditory hallucinations often take the form of disembodied voices that the patient hears talking to them alone. On the other hand, olfactory hallucinations are usually seen in the aura of a seizure in epileptics or patients with brain tumors. Tactile hallucinations exist as well. They're often seen in withdrawal from alcohol, as well as in abuse of cocaine. In both cases, you may hear these hallucinations described as formication, which refers to the sensation of ants crawling on one's skin, not to be confused with fornication. This comes from the Latin word formica, which means ant. And you thought all those years of high school Latin were a waste. Hallucinations fall into one of two categories. Hypnagogic refers to hallucinations that occur while going to sleep, whereas hypnopompic hallucinations occur while waking. You can remember this with the mnemonic pompous upon awakening. Schizophrenia is a very high-yield disorder, so make sure to understand it well. As with many psychiatric illnesses, there's a wide set of diagnostic criteria that you should be familiar with to make the diagnosis. Usually this requires you to remember four things: the distinct criteria that are included, the length of time that's required, the different subtypes of the disease, and related diseases. Most of the framework comes from the Diagnostic and Statistical Manual of Mental Disorders, with the latest version being the DSM-4-TR. This is the consensus text on how to define and speak about mental illness. When clinicians discuss mental illness, this usually is the source for definitions of commonly used terms. The same applies for the information in first aid. Generally speaking, schizophrenia is a chronic mental disorder defined by periods of psychosis and disturbed behavior and thought that last for greater than 6 months. To make the diagnosis, you are required to have a minimum of 2 of the following 5 symptoms: delusions, hallucinations, usually auditory, disorganized speech, often involving loose associations, disorganized or catatonic behavior, and negative symptoms such as flat affect, social withdrawal, lack of motivation, or lack of speech or thought. Within schizophrenia, there are at least 5 different subtypes. It's important to be aware of these, but for the purposes of Step 1, they're simply highlighting the predominant symptoms seen in the patient, and they usually don't cause you to change management. These include paranoid subtype, involving delusions, disorganized subtype, with regards to speech, behavior, and affect, the catatonic subtype, which often involves automatisms, undifferentiated subtype, which has elements of many others, and residual, which has some features long after the majority of features have disappeared. The most confusing part about schizophrenia is that a clinical scenario where a patient looks exactly like they have schizophrenia may not actually be labeled with schizophrenia till they have the symptom for 6 months. If the symptom only lasts up to 1 month, it would be considered a brief psychotic disorder. If it lasts 1 to 6 months, it would be referred to as a schizophreniform disorder. We'll discuss schizoaffective disorder more when we get to the first aid fact on keeping schizos straight. The information about epidemiology is worthwhile to look at, but the Step 1 classically has not tested epidemiological information. However, these patient characteristics are helpful in thinking if the vignette in question is getting at schizophrenia. Let's now approach the following question regarding the subtype of schizophrenia in a patient case. A 42-year-old African-American woman is admitted to an inpatient psychiatric unit after police find her exhibiting bizarre and aggressive behavior in a public square. After 10 days on antipsychotic meds, the patient is able to interact more appropriately with the other patients on the unit. Although she exhibits poor eye contact, her delusions are incomplete and bizarre. She frequently giggles during her daily interviews and smiles broadly when talking about her delusions. The nurses report that the patient's behavior is childlike, and she has a tendency to expose herself to other patients. Assuming the patient has schizophrenia, what subtype does she probably have? It's probably the disorganized subtype based on her speech, behavior, and affect.